Hello, and welcome to Facebook Live with Dr. Brie. I am coming in today from Creatureville, Colorado, the ranch, to let you know about a few updates in women's health after studying for the Menopause Society certification exam. So I have studied inside the box of recent data and recent summaries of the evidence for perimenopause and menopause, and I found some interesting tidbits that I thought you might want to know. So, first and foremost, I've been trending and reading lots of the perimenopause bandwagon stuff. So I'll put a couple of my favorite podcasts recently in the comments, along with the perimenopause roller coaster created by Dr. Brie, myself, and our practice. After 15 years of practicing menopause medicine, I've kind of collected some of the more common symptoms that we see, and just generally shown how, you start with your premenopausal estrogen, you have your postmenopausal estrogen, and the ride is like this, up, down, with a general trajectory down to lower levels over time, and kind of what symptoms you can suspect along the way with a little bit of detail. So I will post those things when this is done, just to kind of go with this discussion. But a few things I thought were interesting. One is there is an official definition of perimenopause, which encompasses really, according to this large study done, the SWAN study, and these kind of stages. Perimenopause is actually three different subsets. There's late reproductive stage, there's your early menopause transition, your late menopause transition, then you have your final menstrual period, which is 1 year after that you're in postmenopause. Okay, so that's the definition. So perimenopause can kind of go from that early menopause transition all the way through that last period and then beyond. Okay, once you have that 1 year past your final menstrual period, you're technically in menopause and post-menopause. So the late reproductive stage is a lot of where we see clients showing up in healthcare practices, especially in holistic practices these days, saying, wait a minute, is this related to changes in my hormones? Though by the box definition, those slight variations in flow, length, or heaviness, or some occasional spotting here and there, isn't technically the early menopause transition until there is a more than 7-day difference in the length of your cycle for consecutive cycles. That's the definition of early menopause transition. So greater than 7-day difference. So you're on a 23-day cadence, and then all of a sudden you're at 30 days for 2 cycles, couple of cycles in a row, early menopause transition. And that's typically when we start seeing enough fluctuation on that estrogen roller coaster that there are changes sometimes in symptoms as well, more consistent with actual, perimenopause vasomotor symptoms, hot flashes, night sweats, especially right before your period. It's also not until that time that we can really predict changes in blood work. And that's why many doctors say there is not a great idea of checking blood work, although there's a huge debate on that, right? In holistic medicine, we check blood work all the time because it can be reflective if you have the right lens to interpret it. The challenge with blood work, I always say, is you get a point on that line, right? So we have our perimenopause roller coaster, right? And then when you get a blood work, you get a point in time on that roller coaster, but you don't know if you're seeing the highest estrogen level somebody has had in months and months, or the lowest estrogen level somebody's had in months and months. And that's why sometimes it's helpful not just to see at estrogen level, but to look at other things like your FSH, which is your brain kind of reflecting on how much estrogen it's seen lately. If it hasn't seen a lot of estrogen lately, the FSH goes up and up. I always explain it's like the brain yelling at the ovaries, make more estrogen. And the higher that FSH is, over 25, the more consistent with, later menopause transition. There is this cool phenomenon that I read about because I've seen it clinically, and it's called the loop. It's basically kind of like a brain chemistry like freak out in perimenopause where you are trying to ovulate and the signals get a little crossed, and basically all of a sudden your estrogen level, and when it should be low, like shoots up, and your FSH becomes suppressed. So this is another reason why interpreting the results has to be done with caution and with a professional who really knows menopause medicine, because sometimes in perimenopause we see these high levels all of a sudden drastically out of nowhere, and you would think, oh, you're not in perimenopause, when actually that is an indication that you are. So it's all over the map for a little while, especially in that late reproductive, early menopause transition phase. But the later menopause transition is a little more predictable in the way that it's unpredictable. So the definition is that you have a cycle change by more than 60 days. So that means you skip a whole cycle or two. Maybe you're having periods quarterly. These are the people that they say, I don't know when my last period was, right? That's a pretty typical sign. And that's when those FSH numbers go up more consistently and your estrogen levels go down more consistently. There are primary indications for hormone replacement therapy, now known as hormone therapy, estrogen and progesterone therapy, primarily by the FDA. So the FDA has approved hormone therapy in women under 60 and ideally within 10 years of the onset of menopause for 3 indications, 4 technically. One is vasomotor symptoms, so hot flashes or night sweats that are disruptive to your brain, to your sleep, to your life. We know they're uncomfortable. It's not just a matter of grin and bear it. That is an actual indication for the use of hormone therapy. The second indication is for genitourinary syndrome of menopause, and that is now the bigger term, which basically means all the changes that can happen in the bladder, in the urethra, in the vagina, in the pelvis. There's a whole host of changes there that can occur, and that is another great reason to use hormone therapy, whether it's systemic or topical, depends on those symptoms and severity. But topical is safe for anyone, even people with a high family history, risk for breast cancer, even with a personal history of breast cancer. If you have genitourinary syndrome of menopause, topical estrogen is safe for everyone. So that's news, hopefully, to some people, get the word out there. The next indication is for prevention of bone loss. It's not a treatment for osteoporosis, although, again, I think that's probably arguable, but based on the evidence, hormone therapy prevents bone loss. And the last FDA indication is primary ovarian insufficiency, which is basically early menopause, typically related to autoimmune conditions, sometimes meds, sometimes other life events like chemotherapy or whatnot. If you have menopause before 40, that puts you in that kind of bucket of really truly early menopause. That's about 1% of the population, so it's not a lot. But if that happens, hormone therapy is definitely indicated until the natural age of menopause at least, which is the average of 51, 52 in North America, so that you can have all the benefits, including the bone loss prevention. So a few other cool things. There are some new medications. There's one, they figured out exactly what causes hot flashes. It's some fancy biochemistry, physiology terms about receptors in your brain, neurokinin receptors, and these neurons, the kisspeptin, neurokinin B, dynorphin neurons. It's this whole thermoregulatory cycle in your brain. So they have a specific medication for that. Lintant, I've never used it, obviously, but that can treat hot flashes alone without any hormone therapy. So if you're looking to avoid hormones but you have wicked hot flashes, that's an option. There's also another one, basidoxifene and conjugated equine estrogen, which is the kind of estrogen we're all told to go away from after the Women's Health Initiative, but it's a new medicine called Duavie, and that's, again, for vasomotor symptoms and prevention of osteoporosis that's non-hormone based. So that one's kind of cool mechanistically. The selective estrogen receptor modulator, the basidoxifene component of that medication, has an agonist on the estrogen receptors in the bone, so it strengthens your bones. But it has an antagonist effect on the breast and the endometrium, so it doesn't stimulate any breast cancer cells or impact the endometrium, where unopposed estrogen can cause endometrial cancer. That's why we have people on progesterone if they're on estrogen. It's kind of a cool product that makes it so you don't have to be on progesterone in case you're progesterone sensitive or can't tolerate it. So that's out there now too. It came out in 2020, so a lot of us just didn't kind of get on that bandwagon. There's a lot going on in 2020. 80% of women will have hot flashes or night sweats for an average duration of 7.5 years. Some people 10 years or more. So it's a long time and it's impactful. It impacts insomnia. Insomnia itself occurs, according to the SWAN study, in 38% of women aged 40 to 55. And it may or may not be related to vasomotor symptoms and night sweats. It could actually be just insomnia of its own. Many people will have this in the luteal phase, in the early menopause transition and the menopause transition. I see that commonly. And that does respond really nicely to hormone therapy often. Depression, very sad statistics here. During the menopause transition, there's 45 to 70% increased risk for depressive symptoms in women compared to 25 to 30% risk in premenopausal women. So quite a big of increased risk there. There's also a systematic review that showed women with bipolar disorder had an increase in bipolar depression symptoms during menopause. Unfortunately, though, we can point to this higher risk of mood disorders in perimenopause and menopause, it's still, studies do not support the use of estrogen therapy to treat the depression, which I was like, that doesn't make sense to me, Western medicine, but okay. Because certainly people on hormone therapy in my clinical experience definitely have mood relief. I think what they're trying to say is if there's a mood problem, you should treat the mood too, and not just say, oh, all you need is hormones. But you also, if you had a mood problem, sometimes you need hormones and treating your mood with therapy or supplements or medications or exercise, all the usual things. So I kind of argue that one there, but interesting statistics. Cognitive changes, I just want you to know, I have a lot of women in our practice who come in thinking that they're going through early Alzheimer's and that they are really losing it, and they may have a family history, and this is when I start to see people really get concerned about their brain health, brain fog, memory gaps, word recall. There are cognitive changes in menopause and perimenopause. It impacts your verbal, episodic memory and processing speed. Those can definitely go down during the menopause transition, but it appears transient and will return to your baseline after menopause. Hooray! Dementia is really rare before the age of 65. So if you're 45 and you're saying this, that, the thing, the thingy, and you're trying to get the words out, but you can't, that's really common. You're probably not actually having dementia, just so you know, even if you're worried about it. Women are 2/3 of cases of Alzheimer's, so it is an increased risk for women, for sure. But there's other risk factors for your brain health that you can kind of address, which, is something we held near and dear to our hearts here with our Direct Osteopathic, has our brain health program and our hormone health program. We have our combined programs too. But the risk factors for cognitive changes, of course, are any mood disorder, depression, anxiety, any insomnia is going to absolutely make that word recall a lot worse. If you're having hot flashes and night sweats and you're up, not getting into those restorative deep sleep stages, you're going to feel worse. Been chronically stressed, you're going to have more pronounced brain fog symptoms. But interestingly, if you have a hysterectomy and they take your ovaries out and it's early in your life, like below 45, which people used to do commonly, your risk for dementia actually does go up. So if you're looking at a hysterectomy, it's my recommendation to my current clients to not take your ovaries out. Let your ovaries go through natural menopause so that your brain health can be improved. But the other typical things, of course, for brain health: don't smoke, don't drink to excess, try to exercise, those types of things. Another interesting one is the arthritis. There's now being recognized an arthritic syndrome of menopause. Many women have increased joint pain in menopause. It's very common. Estrogen is anti-inflammatory. It helps maintain cartilage health and collagen. It is a lubricator of all the things, including your joints. So there is absolutely increased symptoms during perimenopause and menopause, especially as your estrogen levels are dropping. stiff joints, sore joints, more pain, more morning stiffness, sometimes more swollen joints, usually hands, knees, neck, hips. I mean, it's all over. And the key there is it's not like your bad knee that you've had for years and years, and now you get to blame it on menopause. No, the symptom of, the menopausal kind of joint pain is like, gosh, today it's my wrist, tomorrow it's my elbow, today it's my knee, it kind of moves around a lot, and often nocturnal symptoms too. The good news, again, like the brain health stuff, this can be transient and self-limiting, can kind of go back to your baseline after those fluctuations settle down. But more than 50% of women will have joint pain in menopause. And, Asian descendant folks can have severe joint pain and bone pain with perimenopause. So that's interesting to me. Fibromyalgia is 10 times more common in women than in men, but more than 50% of cases of fibromyalgia will be diagnosed after menopause's onset. So that's something to just think about in the back of your mind. If you're in pain, you should get it evaluated, because pain drives up your cortisol and makes your blood work a mess too, as well as how you feel. Last thing, bone health. I mentioned estrogen's a preventer of osteoporosis. I think you should get a bone density a lot earlier than Western medicine recommends. It recommends a bone density at 65 by screening standards, but if you have increased risk, which I think many people do, then you can get an earlier one. We encourage our patients to self-pay for a baseline bone density when they're going around menopause, because your largest drop in your bone density and kind of the largest increase in the turnover of your bone density happens right around that menopause transition. So if you want to self-pay in Colorado for a bone density, it can be like $75 to $100. It's really not expensive. I think a baseline is great, but they recommend it specifically if you have a metabolic bone disorder, of course, if you have low body weight or low BMI, if you have a prior low trauma fracture, let's say you trip and fall and you break your foot, then I would say you need a bone density test. That's not totally normal unless you fell off like 3 stairs. But if you just tripped and broke something, I mean, you might want to get that checked out. Make sure your bone density looks good. If you've been on and off of steroids, not inhaled steroids for asthma, but systemic steroids, like if you had to take prednisone a couple of times for your lungs or bronchitis, you should get a bone density test. There are other risks too. If you've been hyperthyroid, if you're on thyroid medication, and have been on too much at some times, off and on, because that happens with Hashimoto's, then it would be a good idea to get a bone density. If you have a malabsorption issue like celiac disease or inflammatory bowel disease, then you should definitely have an early bone density. And they say in anyone whom evidence of bone loss would lead to treatment. So if you think you would treat bone loss, then you should have a bone density. And if you missed the boat and you're on hormone therapy and you didn't get a bone density test yet, before you stop your hormone therapy, you should have a bone density test to ensure that you don't need to stay on the hormone therapy for the benefit of your bones. So those are the public service announcements about perimenopause and menopause and some updates. The last one is just the importance of the, vaginal health and pelvic health in perimenopause. This has been shouted from the rooftops. Dr. Rachel Rubin gave a great podcast recently. I'll put it in the comments about the importance of treating with topical hormones when you need them. But we see this a lot in perimenopause, so I think it's worth just mentioning that your pH changes. Okay, so your pH in the vagina is acidic, 4.5 or below, before menopause. You go into menopause, and because there's so many estrogen receptors in the urethra, in the bladder, there's estrogen receptors all over the place, in the vagina, the vulva, the bladder, and in specifically in what they call the bladder trigone. They all have estrogen receptors. So as that estrogen level goes down, there's nothing to stimulate those receptors, and we lose collagen, we lose lactobacillus, our good bacteria. we lose this pH balance, and then we see symptoms. And we see not only symptoms of leakage and pain with intercourse, but we also see yeast infections and bacterial vaginitis. And we have a lot of patients coming in with this in early menopause transition. And, they were previously fine with their sexual partner or their bladder or pelvic health, and now something feels off. So a good place to start there is a good probiotic, at least a 20 billion probiotic that has lactobacillus rhamnosus. That is my personal recommendation, not an evidence-based one based on the Menopause Society, because they generally don't recommend supplements. But I think being on a good healthy probiotic is always a great idea. And then just paying attention to your body when you start to feel like you're having these symptoms. Again, topical estrogen, pretty much safe in anyone, and hopefully could get prescribed by people that are not hormone specialists. If you have symptoms of perimenopause and menopause, come on over, check it out. Like, we do our healthy hormone assessment program for non-members, so we can just give you a lay of the land, let you know where you're at. We're always happy to help, and our providers are all doing the certification so that we can give you the most up-to-date information. We're always educating ourselves because this is a changing field, and we like to let you know what's inside the box, also what's right outside the box, and then blend them together. So we do have our favorite local naturopath, Dr. Caitlin, coming to our next Pause Pod, which is just a community fun free event that we're doing every other month. And she'll be talking about botanicals in the treatment of perimenopause and menopause. So look out for that invite, and I hope you have a great day.